with that as a lead-in, Glenn, I'm going to ask you for the audience to talk about this phenomena that as radiation oncologists you guys have observed over time called the abscopal effect. And then I want Evan and Mike to talk about, okay, taking that into account with the abscopal effect, how is this going to influence in terms of other drugs? Evan, you and I talked earlier about double-stranded DNA hits, which is what radium does. So, Glenn, tell us about the abscopal effect.
So we know that radiation therapy can affect the immune response, and a lot of the immunomodulators can really be potentiated in patients that have had previous radiation therapy. Thereby the thought you have an alpha emitter, that's radiation therapy. If you can use that in a safe way and then add additional drugs that are going to be these immune type drugs, it's a very safe toxicity profile. We should be combining them early on.
Yeah, I mean, I guess I'll just add, the theory makes a lot of sense, which is, you use radiation to induce cell death. More antigens, neoantigens are released for your immune system to recognize as targets and to either follow up or combine with some of our novel immunotherapies, whether they're, PD-1, PD-L1 therapies or vaccines, et cetera. So there are a lot of different trials that are happening or will happen in combination with radium and potential PD-1, PD-L1 antibodies. So I think there's a lot of excitement there. I also think, when you talked about, again, back to the point of DNA repair, it's not just PARP inhibitors, it's platinum, it's radium, it's anything that induces a double-strand DNA break that makes it hard for patients with homologous recombination deficiency to repair that. So again, I do think that the future of radium is probably in combination, but we may have patients that are exquisitely sensitive, that have genetic predispositions based on their either germline or somatic alterations that predispose them to really respond well to radium, because it is the only FDA-approved therapy in prostate cancer that clearly induces double-strand DNA breaks.
And I think, going back to, it's a little bit of a digression, but again, this whole issue about it's not for palliation, it really is life prolonging. And who's symptomatic, if you're anemic and you really is because you had a big burden of disease, that may be sort of your signs for anemia. So that sort of wider window of who we can use this in and using a right time for it. The concern I have sometimes is, patients want their PSA to drop. It doesn't always drop. Many times it doesn't. And so it's rising and trying to get them through 6 months of therapy because that's where the survival advantage is. So I think it does take some hand-holding to say we do think it's helping, this is what we know about it, we can add therapies in or continue them on other therapies that may affect PSA to sort of get that sense to make sure that they get the whole course of therapy.
But we do know that patients who get started on radium who have generally a higher alkaline phosphatase level, that is a good marker to potentially follow when they get radium, right? Is if they get a decrease in their alk phos levels, correct?
Yeah, we do see that for sure. So
I think that's a key point. By the time I've seen these patients, they've been living with that number, the PSA number. And their day, or their week, their month is going to be good based on whether their number is going up or down. And so if you use the Radium-223 alone, I always tell patients, we're not going to look at your PSA because I'm not going to impact your PSA in a similar way that Provenge, the immunotherapies in the IMPACT trial wouldn't really affect the PSA. But we do look at, we specifically look at the alkaline phosphatase, we track it before each infusion. So they get an infusion, 3 weeks later they get an alk phos, and invariably it drops. It sometimes bumps up, but that gets them looking and focusing on a number so they can kind of track their own progress, and that keeps them in on it. And when we combine it with something else, if we're talking about some of the androgen receptor inhibitors, then you'll see an impact on the PSA, and then in that case the patient will look at the PSA. But I always stress to them, Radium-223 is not designed to impact your PSA. We've got to look at something else.
Neal, what do you do about in terms of when you start radium on a patient? What do you do about imaging? Do you image? I know some institutions will image after 3 cycles. Some will wait.
So I think it's important to, anytime you're switching your anti-neoplastic therapy, to repeat your imaging. So I always get full body CT, and we're still wedded to technetium bone scan where I practice. So we get that upon initiating therapy. In the 2 phase 2 studies that we did, I did an open label with ABI and radium and a separate open label with ENZA and radium. And we got repeated those scans at 3 months in everybody, and then 1 month post end of treatment. My recommendation would be that you don't need to do that 3-month scan, that's usually pretty wasteful unless you have serological markers that are going north in a very bad way, or the patient is getting new worsening symptomatology, which invariably they're not. But if they were getting worsening symptoms and I was worried about new lesions, really progressive, poorly differentiated disease, or the ALP, other LFTs were going sky high, hemoglobin going down, LDH going up, PSA skyrocketing, and this PSA is, you sort of know it when you see it, and a little bit going up isn't a worry, but that's when I would get scans. But other than that, I don't until I complete the course of therapy. I want to make sure, more and more all of us are thinking you want to really be a little bit more judicious about avoiding over-ordering.
Absolutely. That's one of the biggest things I have. People want to check their work. You don't need these scans other than if there's a real reason that they're clinically symptomatic or the PSA is going through the roof. But my sense is people are checking scans way too often, and it provides no added benefit.
So in the hypothetical situation, if you had a patient after 3 cycles of Radium-223, and say for whatever reason, PSA is going north, LDH is going north, maybe a little bit more anemic, but the patient clinically is stable, no increased pain, and let's say you got a scan, and maybe you've got progression at this point relative to the baseline scan, this whole treatment beyond progression. So in that case, Dr. Yu, would you give the last 3 cycles of radium, knowing that, again, the benefit, and then go ahead and layer in something after the 3rd dose or during that, once you saw this progression on scan?
Well, first off, my approach is very similar to Neal and Mike's approach, which is don't scan unless you're going to do something about it or that you have a real reason to scan. So you put me in a tough position here because I probably might not have scanned this person, but now I did, and he's shown progression. So I have to ask you the question, is this progression new bone mets, or is progression visceral progression? I mean, you have to give me a little more information here because, well, I'll just answer both situations.
He's got both. He's got new lesions, and he's got maybe some new shoddy retroperitoneal nodes about 1.5 centimeters.
Okay, if he's got 1 or 2 new bone mets and maybe a couple small retroperitoneal lymph nodes, I'm going to say, gee, I wish I didn't scan him. I'm going to push forward and try to get him his full 6 doses in. Again, I wouldn't have scanned him in the first place, probably. If he has new visceral lesions or lymph nodes that are growing like crazy, well, then I have to respond to the data that I have. I'd have to change therapy then. But again, without some really strong reason to image him, I probably wouldn't have imaged him at that time point. So,
have you had any experience in giving radium as well as the taxane? I know it's because again that was not allowed on trial. If in Al-Simca, if the patient had planned chemotherapy, they were excluded. But just out of curiosity, either one of you, have you had any experience?
So that's the one contraindication in the label. There's no other contraindication for any sort of additive combination therapy except for chemotherapy, taxane-based therapy. Mike Morris and Oliver Sartor have presented on a trial that was done with giving radium every 6 weeks and a reduced dose of docetaxel, and actually showed a pretty good tolerability profile. And so I know they're working on some additional studies. But I think for the audience, that is technically an absolute contraindication.
And I think as Neal said, that study was when you started them together. It wasn't the layering. Right. So you're on radium, add in docetaxel. So in that particular case, if there were new visceral disease, I probably would switch therapies. But as a combination, I think it is certainly something we have to explore.